Welcome to CPR. My name is Joe Jones. I'm a Fire and EMS Instructor for the State Fire Marshal's Office. I work for the Ohio Fire Academy. I am a full-time firefighter paramedic for the city of Delaware. We take about 5,200 runs a year out of 3 stations right now. We run fire and EMS. So what you're here today to learn about is CPR. Basically what you're doing with CPR is you're pushing oxygenated blood throughout the body. The studies have shown that the earlier we start CPR and we start pushing that oxygenated blood out, the better results we have. If we don't get the electric to them and we just provide chest compressions, yes, we're doing a lot of good for that patient. But what happens is that heart, when somebody goes in cardiac arrest, there's 2 shockable rhythms that we can use. It's pulseless VTAC and VFib. And basically the heart is quivering. It's getting electrical impulses from all over, but it's not causing it to contract. It's not having it do its job. So when we shock somebody, we're basically jump starting the heart. We want to check to see if they're alert. Sir, are you awake? We're going to come down, we're going to look, listen, feel. Notice where I directed my head towards, or my vision at. I'm looking to see if that chest is rising. I'm feeling. Now, keep in mind, anytime you go over top of their mouth, we're putting ourselves at a risk. If they aspirate, if they vomit, we're going to have stuff come up and hit us. So we got to worry about that. The contact with body fluids. We'll check for a carotid pulse. I want to check it for no more than 10 seconds. Call EMS, get me an AED. If I do not feel a carotid pulse, I'm going to automatically start in on chest compressions. Now notice I'm allowing for full chest recoil on this. What's the ratio I'm going to do? 32. Okay. I'm going to manually open this airway using the head tilt chin lift. If you suspect that they fell off of a ladder, if they fell over off of a railing, then we're going to do what's called a jaw thrust, a modified jaw thrust. We're going to hold their head in an inline position because they're probably going to have spinal injuries. And all we're going to do is manually open their airway with our thumbs. It's kind of difficult with these mannequins, but just keep that in mind if it ever happens. But we're always going to manually open these airways. Now notice there's a pause there between my breaths. I give a breath, I'm looking for that adequate rise and fall in the chest. Then I give my next breath. We have somebody that shows up with our AED. Okay, so I've turned it on. I'm going to hook up my electrodes. I'm going to put this on his chest. Well, this gentleman here has a really hairy chest. Really, really hairy. Like a gorilla, like a grizzly bear chest, okay? These will not stick. Or he's really diaphoretic. He's really sweaty. What can I do? What did it show you to do if they had an internal pacemaker? An inch down or to the side. We can still put it over to the side if we have to. As long as we're getting contact with the skin, that's what we're after. All right? All right, so I'm going to hit the yellow button to analyze. And once again, this is going to be looking for pulseless VTAC or VFib. Now notice it's charging right now. A lot of people, as soon as they hear it, don't go ahead and hit the shock button. It's not going to deliver the full amount of joules, so you need to let it go until it tells you to shock. Clear? Everybody clear? Shock delivered. And you will know when the shock is delivered. The body will. will bump. You don't want to be in the middle of doing chest compressions when he hits shock, because it will transfer into you. And it's not a pleasant feeling. Believe me, I've had it happen to me. What little hair I had was standing straight up. So that's why we want to go ahead and make sure everybody's clear before we deliver that shock. As soon as we deliver that shock, we go right back to doing our chest compressions. Okay? Typically, we can keep giving shocks. These will probably stop after about 3 shocks. All right? The big thing is activating EMS. The sooner we get CPR and we get the AED to them, the better survivability rates are. So even if you only have to shock them once, as long as you're doing effective CPR and you're pumping that oxygenated blood throughout the body, good things are going to happen. It's going to increase the chances of survival for that patient. Interlock your fingers, mid-sternum. Allow for full chest recoil. If you do 32 compressions before you hit those 2 breaths, is it going to hurt them? No. If you go 29 compressions before you get to those 2 breaths, is it going to hurt them? No. If you go 4 compressions and then give breaths, and then go 5 compressions and give 2 breaths, is it going to hurt them? Yes. What happens with any tissue in the body, if it's ischemic for enough time, it starts getting necrotic, which means it starts dying. So we do those four compressions, and then give 2 breaths. Basically, we're hyperventilating them at the core, but we're not pushing it out to the rest of the body. That's why we do the 30 to 2 to get it out and let it come back. So we're getting that perfusion, that exchange of the good with the bad, and we're doing the whole cycle.
Connect electrodes. Push analyze. Stand clear. Analyzing now. Stand clear. Shock advised. Stand clear. Push to shock.